So I'll be talking about the final overall survival from PROSPER trial, a phase 3 randomized double-blind controlled trial, double-blind placebo-controlled trial, enzalutamide in men with non-metastatic CRPC. So we have already saw that the initial results of metastasis-free survival, and now this is the final overall survival analysis. So the median bone mets-free survival among men with non-metastatic CRPC ranges from 25 to 30 months, and the risk of mets is associated with increased PSA and a PSA doubling time of 10 months or less. So metastatic CRPC is fatal with median survival of approximately 3 years. Delaying time to metastasis is clinically relevant and may delay cancer-related complications. We know that enzalutamide, it binds directly to the androgen receptor and inhibits the binding of androgens, androgen receptor nuclear translocation, and androgen receptor mediated DNA binding. Its effect on overall survival has been shown in 2 international phase 3 trials involving patients with metastatic CRPC before and after the receptor of docetaxel. So this phase 3 PROSPER trial had previously demonstrated a statistically significant, clinically meaningful improvement in metastasis-free survival with a in men with non-metastatic CRPC and rapidly rising PSA. This we have PSA who received enzalutamide, right? So when first reported, the OS data was immature with only 28% pre-specified deaths. So the final OS analysis of the phase 3 PROSPER trial is recently reported at the virtual ASCO annual meeting 2020, abstract number 5515. So in this trial, men with non-metastatic CRPC having a PSA doubling time of less than 10 months and PSA of more than 2 nanogram per ml at a screening continued androgen deprivation therapy. Hello? Yeah. And were randomized in 2:1 to Enza 160 mg or placebo. The OS treatment effect was assessed using a group sequential testing procedure with O'Brien-Fleming type alpha spending function. And medians were estimated using Kaplan-Meier method, 95% confidence interval using a stratified cost regression mode. So you can see the study design. Patients with non-metastatic CRPC and PSA doubling time of less than 10 months were randomized in 2:1 to enzalutamide 160 mg once a day plus ADT versus placebo plus ADT. So the primary endpoint, we already know it's a metastasis-free survival. The secondary endpoints include safety, time to progression, time to next therapy, OS, PSA response, and quality of life. These are the baseline characteristics of patient in where we can see that in both the arms, baseline characteristics are well balanced. So we directly come on to the result with a data cutoff of October 15, 2019. The median follow was approximately 48 months. There were 466 and 178 deaths in enza and placebo arms respectively. So it is almost 31% deaths in enzalutamide arm and 38% death in placebo arm. So you can see that enzalutamide significantly prolonged OS compared with placebo with a hazard ratio of 0.73 and p-value significant. So the median OS was 67 months in enzalutamide arm and it was 56.3 months in the placebo arm. Subsequent antineoplastic therapies were initiated after treatment discontinuation by almost 33% men in enzalutamide arm versus 65% in the placebo arm. Now this is something which is very important, that even after treatment discontinuation, almost 65% of the patient in the placebo arm. Yeah. So these are the Kaplan-Meier survival curve. So you can see that patients on enzalutamide arm, they have a median survival of median overall survival of approximately 67 months as compared to 56.3 months with hazard ratio of 0.73. So median duration of treatment was 33.9 months in the enzalutamide arm versus 14.2 with placebo. More than grade 3 adverse events were reported by 48% of the men in the enzalutamide arm versus 27% in the placebo arm. And out of which almost 16 versus 6 were drug related. Adverse event with event rate less than rates per 100 patient year that were more than 2 points higher with enzalutamide versus placebo were falls, fatigue, and hypertension. So no doubt this falls, fatigue, and hypertension were more with enzalutamide arm. So you can just see this key safety outcomes wherein there's more than grade 3 events were little higher in the enzalutamide arm as compared to the placebo arm. So to conclude, this enzalutamide was associated significantly prolonged OS versus placebo, 67 versus 56.3. Enzalutamide treatment resulted in statistically significant 27% reduced risk of death compared with placebo, demonstrating that initiation of enza plus ADT before the onset of detectable metastasis improve OS in men with CRPC and rapidly rising PSA. This OS benefit was achieved despite crossover from placebo arm to enzalutamide arm and high rates of subsequent antineoplastic therapies in men from the placebo arm. So, this final OS analysis from PROSPER provides prospective validation of metastasis-free survival as a potential surrogate endpoint for OS in non-metastatic CRPC and support the continued use of enza plus ADT as a standard of care in men with non-metastatic CRPC and rapidly rising PSA. Safety was consistent with previous trial. So if I have to conclude about this trial, it was an interventional double-blind randomized placebo-controlled phase 3 trial. Enza plus androgen-dependent therapy led to a 70% lower risk of metastasis or death and 22-month delay in development of metastasis as compared with placebo. There's increased toxicity in enzalutamide groups with more fatigue, fall, and fractures. There was also increased cardiovascular events and death, even though the study excluded patients with clinically significant cardiovascular disease. So the clinical question in this PROSPER trial was to whether to start therapy in patients who have rising PSA level as the only manifestation of disease worsening with no disease on imaging. So that is something, this clinical question in this PROSPER trial, which they need to answer. And this question was answered in trial for early versus late therapy and improvement in all secondary endpoints despite subsequent line of therapy. The increased adverse event as related to falls, seizure, and increased cardiovascular event require mention. And benefit is also unproven in patients with longer PSA doubling time because they have taken, they have a defined PSA doubling time, right? So, enzalutamide for non-metastatic prostate cancer represent important step forward for men with rising PSA level during androgen deprivation therapy. And the benefit risk evaluation suggests that treatment with either drug is better than waiting until the appearance of metastasis. But before I conclude my talk, I just wanted to know from the house also. Now there's a real confusion which drug to prefer in non-metastatic CRPC. We have a PROSPER trial wherein enzalutamide is the drug. We have a Spartan trial for apalutamide. We have Aramis trial for darolutamide. And we also have an Imagine phase 2 trial for abiraterone. With this, I just thank my organizers for giving me this opportunity. Thank you very much.